Hello, everyone. I'm Ann Partridge, and I'm so pleased to be here with you tonight and with our illustrious panel. I'm a breast medical oncologist at the Dana Farber Cancer Institute, where I also serve as the director of the Adult Survivorship Program and vice chair for medical oncology. And I'm here tonight. First, we'll introduce everybody, and I'll start with kind of my romper room going around the square instead of the circle. Dr. Matthew Goetz. Do you want to start, Matt?
Thanks, Ann. My name is Dr. Matthew Goetz. I'm also a medical oncologist focusing on breast cancer. And I lead the breast cancer research group at the Mayo Clinic here in Rochester, Minnesota, and very pleased to be a part of this panel tonight and to reflect a bit on San Antonio this year.
Thanks, Matt. And we also have Dr. Elyse Lower. Elyse?
I'm also honored to be here, and we don't have any snow like Rochester probably has. But I'm also a breast medical oncologist, and I'm the director of our University of Cincinnati Comprehensive Breast Cancer Program. So thank you, and I look forward to everyone's participation, including the audiences.
Thank you, Elyse. And we're going multidisciplinary tonight, of course. So now I'd like to introduce, or she'll introduce herself, Dr. Kristina Mirabeau-Beale.
Thank you. So I'm Dr. Kristina Mirabeau-Beale. I'm a board-certified radiation oncologist. I did my training at the Harvard Radiation Oncology program between Dana-Farber and Mass General, and now I'm in community practice in Fort Myers, Florida. I work with a group called Genesis Care USA, which was previously known as 21st Century Oncology, and I'm also the director of our community breast cancer program at our regional cancer center here in Fort Myers.
Thank you, Kristina. And Dr. Terry Mamounas.
Hi, I'm Terry Martens. I'm a breast surgical oncologist. I'm a director of the Comprehensive Breast Program at the UF Health, Orlando Health UF Health Cancer Center here in Orlando, Florida. And I also chair the breast committee of the NRG Oncology.
Thanks, Terry. Salila Kurra, doctor?
Hi, good evening. I'm Salila Kurra, and I head of the Adrenal Center at Columbia University in New York, where it actually has started snowing already, but it's nice to be here tonight, and thank you for inviting me.
And Salila is going to help us with all of the endocrinopathies that we all fear. So we'll talk about some of those in theory. And then finally, last but not least, the most important person on the panel, Ms. Jessica Owen, who will tell us her story. Jessica?
So, hi, thank you. I have to say I'm humbled to be included on this panel. And I will say that I've been asked to give just a few details about my background. I worked as a high school counselor, and I've worked as a school counselor for over 20 years at multiple levels. And I was living my life, raising my two adopted children who are currently two teenage boys who play a lot of soccer, and very, very active. I've competed in triathlons. I mean, I was ruling life, and I had a couple of scares with mammos that did not look good. Had a surgical biopsy, had a couple needle biopsies, all were false alarms, and then in time developed an inverted nipple. I went to the radiologist. They felt that it was probably just aging tissue presenting. So I went home for another year, and a year later I went back, and I said, this doesn't feel right. And at that time, did additional biopsies, and then it turned out that it was the news that you don't want to hear. So then I got a great surgeon, had a bilateral mastectomy, went through chemo and radiation, finished radiation about a month ago, and here I am on the other side.
Thanks, Jessica. And the dog's making a cameo voiceover, so please forgive if anybody hears that out there. And we're going to ask you a few more questions about you as we get going. But before I start asking the panel to comment and talk about some of the topics that came up at San Antonio that are relevant to what you've been through, and of course we'll generalize it, I just wanted to say thank you to our sponsors, Agendia, Pfizer, and Biotheranostics for the support to make this happen tonight. So Jessica, thank you for bravely sharing your story. And it sounds like, and of course you shared it with us previously, you presented with a hormone sensitive, ERPR positive, HER2 negative tumor that was big enough to pull on the nipple and be large enough that you needed to have a mastectomy up front, correct?
That's right.
And so, you know, when we see this in our practices, and Terry, Kristina, please feel free to chime in. This is something when someone presents, and obviously you presented, and I don't know if you said the dates, but you presented right as the pandemic was starting. And so we changed things up a little bit, even in how we cared for patients at that time. But when people present with a tumor that's large enough and pulling on the nipple, you know, how do we think about that? And maybe I'll start with you, Terry. You know, relevant, did we learn anything new at San Antonio about that you want to comment on, and we can all chat about it?
Yeah, so I mean, nipple inversion is, as we all know, often a pathognomonic sign of breast cancer, but not always. Sometimes the breast cancer doesn't necessarily have to be behind the nipple to cause nipple inversion. It can be further deeper in the breast, but pulling some of the ligaments of the breast and inverting the nipple. So when we have this sign, we obviously look for both sides. I think what you've been told of this aging nipple, I think that's something that can happen sometimes. You know, women's nipple may invert, you know, later on in life, or when you lose some fatty tissue in the nipple area, and that's not necessarily some sign of disease. So we'll look at, you know, symmetry, of course, if this happens in both breasts, and also if the nipple eventually everts again, you know, when you stimulate it. But often, obviously, we have to take it very seriously, because it could be the sign of a breast cancer growing in the vicinity of the nipple or further in the breast. So that's something that requires very careful assessment with, you know, obviously imaging, mammogram, ultrasound, often an MRI, just to make sure that there's nothing that we're missing.
Thanks, Terry. And Kristina, when you think about that, does that change the way you think about if someone presented like that, how you might do your craft as a radiation oncologist?
Well, definitely that's where the the clinical exam comes into play. You know, sometimes we worry about something like a Paget's disease of the nipple, or whether there's an inflammatory component versus locally advanced breast cancer. So I think that's where it's very important for us, kind of as a multidisciplinary team, to be part of the exam process kind of early on, even meeting patients before surgery. Definitely that made us more concerned about, you know, our patient, rather than just by imaging alone sometimes, or even the description.
Thank you. And obviously, Jessica shared with us that she opted for bilateral mastectomy, and there were some anatomic reasons for that, as well as, I'm sure, personal preferences. And Matt and Elise, do you want to comment on when, you know, Terry and Kristina, and you were seeing someone in your multi-D clinic, and they present with a larger than we'd like tumor, and how do we help to decide what might go first? And if we're going to do neoadjuvant therapy, and her tumor was hormone sensitive and HER2 negative, at least in terms of its receptors, how do we think about that? Elise, do you want to start?
Sure. You know, I think clinical exam is obviously very, very helpful. And clearly in the past, if you had those nipple changes, I think we would have said you have to have a mastectomy, but we would get an MRI and take a little bit better look at, make sure there's no other disease elsewhere. I think you made your decision pretty easily that you wanted a mastectomy, which means you may or may not have had the MRI since you made that decision. But under other circumstances, looking at the location, the size would help us to try to offer neoadjuvant. And I suspect your cancer was at least 2 centimeters from what you're saying. And that's kind of our cut point for the ER positive tumor. That's when we would offer neoadjuvant treatment. And I think one of the interesting things today, and I'm going to pass the football to Matt on this, is if it's an invasive ductal cancer that's ER/PR positive, HER2 negative, would you offer neoadjuvant hormone therapy? Would you always offer chemo? And if it were lobular instead of ductal, I don't know, Matt, do you have thoughts on what kind of neo you would offer?
And I want to add before you go, Matt, would you get any other testing on the tumor to consider, especially when a young premenopausal person comes in?
Yeah, so these are all good points to address. And I also think, you know, in the midst of COVID, we started thinking about doing this all perhaps in a different way. We were all faced with the fact that, you know, that there was almost a bit of rationing of care in the sense that there was only so many ORs that were going to be available. And so we started trying to figure out, well, who needed to go to the operating room, let's say tomorrow, this week, versus someone that could actually be treated with neoadjuvant, some sort of neoadjuvant therapy. And I think one of the most amazing things about, there's been a lot of bad things about this year, but one of the most amazing things about this year is we were able to take what we've learned about the care of patients and what we've learned about the neoadjuvant treatment of breast cancer patients and utilize that in a way that I think really did help women out during this period of time, where otherwise in the past we would have probably said, well, we're not sure who can or who could not, should it be going to the OR tomorrow versus the next day. So certainly what we have been doing in this particular situation, to answer Ann's comment, is to get information, try to get as much information about those factors that would affect response to chemotherapy and endocrine therapy. And so, Ann, I think you're talking about certainly about medical genetics testing, maybe not so much about whether that's going to affect response to chemotherapy, but certainly decision making at the time of surgery. You don't want to, you know, go into that really in the dark. If you could have that information, I think that's helpful. And then, Elyse, with regard to what you're saying, you know, typically, and what we've done in the past is we've tried to get an understanding of the endocrine sensitivity of the tumor. And so we've used, you know, classically information about the level of the estrogen receptor, the progesterone receptor, although progesterone receptor typically gives us more information about prognosis, perhaps, than necessarily endocrine sensitivity. Obviously HER2, because that's a critical factor that would affect how we treat patients in the neoadjuvant setting, or whether we would. And then finally, Ki-67, which is done at some institutions and not others. What we haven't been doing, of course, in this situation is getting a recurrent score or some other genomic predictor in the preoperative setting routinely. I think we've been using it more in the postoperative setting. And so that's where I think there was some new data that was presented at San Antonio. It was quite interesting about how we use these markers. And I think the real, to me, one of the very, very interesting or two interesting abstracts relate to this whole issue of assigning neoadjuvant endocrine sensitivity. So giving a preoperative course of, or giving a course of neoadjuvant endocrine therapy, and then using that information to make decisions on chemotherapy or whether to continue on with endocrine therapy. And so that all this information, by the way, is something that we can now use to really, certainly to better take care of our patients. But I think we really took advantage of this information in the last 9 months when we were really pushed into a situation where we had to make decisions about who needed to go to the OR sooner rather than later.
Thanks, Matt. And I think, you know, you're talking about the alternate and the ADEPT trials that were presented at San Antonio, where they used Ki-67 to triage in at least postmenopausal women, whether they were responding to pre-op endocrine therapy. And then if they weren't, then they moved them into chemotherapy. And what are your thoughts on Ki-67? And maybe others can comment on the panel. Do you think this is something that, you know, should we be using other tests? I will actually tell you that we actually, especially during the early part of the pandemic, especially when we were putting young women on neoadjuvant endocrine therapy to help them not go through chemo if they had, you know, lower risk hormone sensitive breast cancer, and we weren't sure when our ORs were going to open up again. We actually did send Recurrent Score not infrequently. And of course, there are other genomic expression profile tests that you can do, like, you know, MammaPrint and others. And we'll talk some more about that, of course, tonight. But what do you think of Ki-67 for all that?
Well, I think, you know, the studies that have been done, and I'll talk a little bit about the ADAPT study. So exactly as you said, they did, the West German group did a sort of a run-in, you know, a 3-week, in some cases 4-week run-in of neoadjuvant endocrine therapy. And they actually enrolled both pre and postmenopausal patients. And they also obtained recurrent score data information. And I think one of the things that's quite interesting, and this also plays into this, a paper that was just published by Mitch Dowsett and his group literally in just a few days ago in the Journal of Clinical Oncology, which suggested that the recurrent score, that one of the major drivers of the recurrent score is actually the estrogen module. And it's not the proliferation marker or the proliferation module as we all sort of think about. I mean, many of us for a period of time thought that we could all figure out the recurrent score just by, ERP or HER2 and Ki-67. We thought, we could do it in our heads. But I think as it turns out, much of the drivers, molecular drivers in the recurrent score is really the endocrine module. And so what that means is that there's still quite a bit of variability as it relates to proliferation. And that's exactly what was seen in the ADAPT study. What they saw was that in patients who had recurrent score 0 to 11 and then 11 to 25, that group of patients, 11 to 25, there was a substantial number of those patients with a with a preoperative run-in of endocrine therapy that clearly did lower their Ki-67. They used a cutoff of 10%. There was also a group of patients, interestingly, with a high recurrent score greater than 25. Patients with a recurrent score of 30 or 35, and actually about a third of these patients also had endocrine sensitivity as well. And at the end of the day, what they showed in that study, there was two aspects. One of them was if you had an endocrine response in the midst of, a recurrent score of 0 to 11 and 12 or 11 to 25, excuse me, that those patients with an endocrine response did just as well as somebody had a recurrent score of 0 to 11. But conversely, if you didn't, those patients, they went on to ask a chemotherapy question in the other part of the ADAPT study. And the suggestion there was that in patients receiving a standard preoperative chemotherapy regimen, anthracycline, taxanes, they looked at the question of nab-paclitaxel. But the suggestion there was that patients with not only higher recurrence score, but intermediate recurrence scores with endocrine unresponsiveness, as assessed by a short run-in of Ki-67, really did benefit from chemotherapy. Now, that actually is contrast to the alternate study. And the alternate study, as you all know, looked at the role of neoadjuvant endocrine therapy and was really designed to validate the PEPI score, the modified PEPI score. And at ASCO, when the primary comparison, of course, was an AI fulvestrant or the combination, there didn't appear to be any differences between those three arms. But one of the things that was presented by Cynthia was an analysis of the endocrine unresponsive group in their response to chemotherapy. And really the response rates were very low as it relates to RCB scores. In fact, most people were in that 2 to 3 range. Now, there was some issues, of course, with the fact that not all patients received a standard chemotherapy regimen. Some patients it was taxane alone. Some patients it was, not perhaps a standard regimen. But nevertheless, I think we were a bit surprised at the lack of response to chemotherapy with the alternate study.
So we don't have long-term follow-up on that.
Correct. That's exactly right. Yeah.
Yeah, and we
So
don't
I think what just to follow up on that, and I'm going to stop talking. To me, the question that comes up is, we all know the value of using these genomic markers, whether it's MammaPrint, whether it's recurrent score, they clearly have value. But the ADAPT study suggested that we're missing something, and that is there is a group of patients with the so-called intermediate risk group, and maybe even a subset of the high risk group that are truly endocrine responsive and may not need chemotherapy. And that's really what their data suggested. And so the question I think coming forward is, should we use these multi-gene markers along with a dynamic response? And that will, of course, the dynamic response is a 3 to 4 week run-in. And I'd love to get other people's thoughts on that, about what they think about that.
Yeah, thank you, Matt. And I have a couple questions, but I just want to pass the mic to Jessica, because that's the perfect opportunity to say, Jessica, if you did a run-in with hormonal therapy and you had a beautiful response and someone said, at least biochemically in your tumor or there was shrinking, and someone said, we don't think you necessarily need chemotherapy, would you have jumped at that, or would you be afraid of that?
Well, here's the thing, as a patient, it's really difficult not to engage in fear-based decision-making. And as a patient, we really rely on you as the experts to really try to give a little bit of, synopsis of why you would guide me to do one or the other. But I will tell you that when you cite these statistics, unless you can tell me exactly the reason why I will fall on the good side of the statistic, I want the treatment because I'm already in your office. I already came up on the bad side of the statistic and I don't know why. So give me the treatment.
Understood and appreciated. Thank you. But we do try and not give people treatments that we don't think will add value. And when we can show people that, that's what you want to see. Yeah, for your comfort level. Thank you. All right, we have some questions from the audience before we keep going on this line. And I want to get back to just presenting with nipple inversion. And maybe Terry, you can answer this quickly. We alluded to this. If you have imaging that's negative, what's the next step? And is it okay to follow up in 4 to 6 months? What additional studies are indicated? So a person presents with just nipple inversion with or without a mass, obviously you'd have to, I assume it's different if there's a mass or not.
And it depends on, obviously if it's sort of bilateral nipple inversion is less suspicious with negative imaging, but sometimes even unilateral, but if the nipple everts, and then again, imaging doesn't show anything, but that would probably include an MRI in my book. I would not go on just with a mammogram and an ultrasound. I think we then follow the patient and we repeat, exam and potentially imaging again in a few months, 3 to 4 months, just to make sure that there's nothing there. But MRI is actually a pretty good guide to tell us that there is no malignancy. If the MRI is entirely negative, behind the nipple particularly, there is no enhancement whatsoever, I think it's probably just an anatomic, development, which sometimes is because you lose some of the fat in the subareolar area, and then that kind of sinks the nipple in. But it's not a true inversion because the nipple can come out. It becomes more flat, or sometimes it everts just temporarily. So you have to have proper imaging before you can get to that point.
And another question from the audience was, using the ADAPT trial data, would you offer neoadjuvant endocrine therapy in node-positive patients, for example? Elyse, do you want to take that one?
I think ADAPT was in the node-positive population. So for certain, I would offer it in that setting if we feel compelled. I do think that I like this concept that we're able to add something different, be it Ki67 or perhaps maybe even circulating DNA. I don't know. But I am a little concerned about Ki67 as a marker because there's so much pathologic lack of, I guess, specificity, really. The numbers vary all over. And I know when you're in the community and you look at the report, whether it's they call it a MIP or they call it a Ki67, and our pathologist will confirm that about a third of the time we don't agree. And I'm very concerned about trying to take Ki67 as our marker and adopting the ADAPT for general public when we can't really generalize it. So does that mean that every person has to have a central confirmation of their Ki67? Perhaps it does. But I think it's going to become very problematic if we let local pathologists interpret the Ki67 if we're going to make big decisions. So I worry a bit about that. Not that I don't think it's a great idea, because I think sparing women chemotherapy is great. I say this as a medical oncologist. Whatever we can do to minimize side effects, get the best outcome is what we should do. We should have the most aggressive, most appropriate treatment. So I'm very in favor of that. I'm just not sure Ki67 is the right marker for the general populace.
Yeah, and I think many agree with you on that. Sorry, Terry, did you want to say something?
Yeah, I want to say though that question has become now more complicated with the results of the Responder trial, which I'm sure we'll discuss here because of the potential benefit either from chemotherapy or indirect endocrine effect, which we're not sure. But certainly the benefit is there one way or the other. So it's hard to avoid the chemotherapy for no positive, at least premenopausal patients. For postmenopausal patients, clearly, that's a very good approach.
So
I think
now,
it will be interesting to see, and Dr. Kalinsky referred to this, how much data is going to be coming out from the RX Ponder as it relates to, you know, the benefit in, or if you will, the chemotherapy-induced menopause benefit in that group, because obviously they didn't have those data, they didn't present those data. That is, those patients that became amenorrheic versus not.
Let's hold that thought for a sec, Matt, because we're definitely going to talk about that. But I want to ask Dr. Kurra quickly, and quickly pass the baton to you. You know, we are throwing around these drugs a lot with good intentions, where we give people chemotherapy and we send them into premature menopause, or we suppress their ovaries, and then we also give both pre and postmenopausal women, when their ovaries are suppressed for pre, we give them a lot of aromatase inhibitors. And when you think about that as an endocrinologist, and you think about what we're doing with their bones in particular, and I'll specifically ask, let's pretend we're still in the neoadjuvant setting, and we've decided we're going to treat a senior with 6 months neoadjuvant, but then they typically get at least 5 years and sometimes up to 7 or 10 years of adjuvant hormonal therapy with an aromatase inhibitor. How would you recommend we approach their bones in that setting?
Sure. So, you know, as an endocrinologist, we think about bones all the time, and we're maybe a little bone centric, but, you know, I think the conversation is very different depending on whether you're premenopausal or postmenopausal. A lot of times postmenopausal women who've been treated with chemotherapy or with endocrine modulators really end up in a similar situation than somebody who was not treated. And fortunately, we have a lot of great medications to treat postmenopausal osteoporosis or osteopenia, and almost all of them can be used in the setting of having had breast cancer before, with the exception of Forteo, which is teriparatide, which is the only anabolic we have. So all of the other medications we use are anti-resorptives. So they stop you from losing bone, but they don't really build bone. Whereas Forteo or teriparatide is an anabolic and you make bone. But we all are scared to use that medication for the fear that if there's a microscopic metastatic cell in the bone, that we don't want to stimulate that and make it grow. So that's the only medication that we can't use. So other than that, we can use the rest of the bone medication. So we don't worry as much about bone in the postmenopausal setting because we can use all of these medications. In the premenopausal setting, it's a little bit different because, you know, if you lose a high level of estrogen in your 30s or in your early 40s, then you have a longer time where your bones don't have estrogen, and it may be harder to treat in the future. And typically, if somebody went into early menopause for some other reason, we would consider something like Forteo an anabolic to build bone. But in this situation, we're limited a little bit to using the anti-resorptives, and we typically don't like to use those medications until people are at least in their 50s because of the safety data associated with using these medications for more than 5 to 10 years, where you can start to see some of these atypical fractures, which is you can break your thigh bone. And so that's why we like to try to hold off on using them until people are older.
So in breast cancer, where we have some data that not everybody believes in, but a large meta-analysis that suggests that the breast cancer is actually risk reduced by getting bisphosphonates for up to 5 years. Do you suggest that we stop it after 5 years, especially when we're giving it to a young person, and then kind of reassess, as opposed to keeping going for the treatment of osteoporosis if they tend to develop that subsequently?
Yeah, I mean, I think if the data are strong that it prevents the recurrence of breast cancer, then I would not suggest stopping a bisphosphonate. We use bisphosphonates for longer than 5 years if someone's had a compression fracture of the spine, because there are data that prevents further compression fracture. So there are situations where we will use bisphosphonates for longer than 5 to 10 years. It's just that in the past, people would get bisphosphonates and just stay on them even preemptively before they had osteoporosis. So that thinking has changed dramatically. But there are several situations where somebody would benefit from being on a bisphosphonate for almost indefinitely.
All right, so the answer to us medical oncologists is, if you're going to do it, 3 to 5 years, depending on which study or the meta-analysis you're following, and then get them off if they don't have osteoporosis, because they might need it again someday. How about that? Is that good?
Yeah.
Okay, good. Thank you. All right, so let's get back to I think the biggest news, which we started to talk about, which was our exponder. or responder, however they say it. I noticed Dr. Kalinsky said responder, so I'm going to try and say it correctly. You know, for women with node positive breast cancer and who had a recurrent score, there were differences in terms of how they did, whether you were premenopausal or postmenopausal. So just to bring this down to the level of a person, let's pretend that we have a patient here that had node positive disease. Jessica, your disease was not node positive, correct?
It was.
Oh, it was. Well, there you go. Sorry. And so you had how many nodes involved?
4 were removed, 1 was involved.
Okay, so 1 node positive, and the tumor ended up being how big?
9.
Okay, 9 centimeters. Okay, and you had a mastectomy, and so you had a 9 centimeter tumor, and it was what grade?
3.
3. And someone sent a recurrence score on your tumor, which is really interesting, correct?
Mm-hmm.
And what did that recurrence score, what was the score?
The oncotype score, is that what you're referring to? I'm trying to keep up with all your jargon here. The oncotype score was 13.
13, which is super interesting. And certainly before San Antonio, many of us would have kind of wrung our hands, but given you chemotherapy. And then afterwards, we probably still would give you chemotherapy, to be honest. I'm cutting to the chase. But how do you guys want to react to that? So let's start with Matt, because you started talking about this. So after San Antonio, you have a premenopausal person coming in, node positive disease. Let's pretend, 1 to 3 positive nodes, oncotype score less than 25, but in the historical low range. Do you want to go back to what you were talking about earlier?
Yeah, so I think there's 2 parts of this presentation that were very important, and it's quite interesting that SWOG, the statistician and the group really had the foresight to be able to look specifically at the importance of the difference in outcomes, not only, by the way, with regard to the interaction, let's say with recurrence score. So in other words, there was this thought when we all started using the recurrence score was just the higher the recurrence score, that the greater the benefit of chemotherapy. And so that was certainly something that they looked in. They didn't see that. Certainly they did see that the recurrence score was prognostic, and that was known. But what they saw, of course, was this interesting phenomenon that was also seen in TAILOR-RX, and that was that patients who were premenopausal and were in the recurrence score, both in the 0 to 10 range, as well as the 11 to 25, benefited from adjuvant chemotherapy. But that, of course, was premenopausal. In postmenopausal women, there was absolutely no benefit of chemotherapy. So I think that there's 2 things that came out from this. Number one is that obviously we're talking about the premenopausal setting right now, but just as a quick aside, for women who are postmenopausal, 1 to 3 positive lymph nodes, I think we can confidently say to those patients right now that there's no benefit of adjuvant chemotherapy. And I think we still, even in the last couple of years, we sometimes will get, these genomic tests not covered by insurance, and then that part's been difficult. So I think that's very reassuring. We have those data. Now, what about the premenopausal group? Well, this is where, again, there was a benefit of chemotherapy, and I have the slides up in front of me right now, but the 5-year IDFS benefit was almost 4% in a recurrence score 0 to 13. And recurrence score 14 to 25, just a little bit more, was 6%. And so the suggestion, and it's exactly as you said, well, we would think about someone with a recurrence score of 3, or a 5, this is going to be a highly endocrine sensitive tumor. We shouldn't be giving chemotherapy to that group. Well, lo and behold, there is a chemotherapy benefit. Of course, now there's a lot of questions that are raised, and you brought up one of them, of course, and that is, well, what about menopausal status, patients that were or were not rendered amenorrheic by chemotherapy? And also, I think there's another question, and that is that premenopausal patients tend to be enriched with genomic variants that we know are associated with chemotherapy response and DNA damage. So for example, if you are age 35 or 40, you're more likely to have a genetic variant that's associated with not only the risk of developing breast cancer, but also response to chemotherapy. So is some of this benefit that we're seeing in so-called endocrine sensitive tumors simply related to the baseline genomic, the genetic variants that, let's say, led to the development of cancer in the first place? I think that's also an open question as well. I don't think we have really looked into that carefully as of yet.
Thanks, Matt. Elise, what do you think? Are you comfortable not giving chemotherapy? Well, now, so postmenopausal woman comes in and she's got a low recurrence score below 25 and has 1 to 3 positive nodes. On Monday morning, are you comfortable not giving her chemo? Last Monday?
I actually am quite comfortable with 1 positive node. I think that, and again, it's very a little bit by institution. We used Mamounas in our institution for node positive disease, and really used, because it gave us a little bit more information than the oncotype specifically did. And we felt that the data was there with MINDAC and so on. So we pretty much switched our pre and postmenopausal women that had 1 to 3 positive nodes to Mamounas. And so we're pretty used to now using no chemo in the postmenopausal woman who has a low score. And I would say the same thing with the low recurrent score. Premenopausal women, I'm still not confident saying that every one of them with 1 positive node is going to benefit from chemo. I'm not sure. That's the area that I still think is gray. And I'm not totally comfortable with that. And again, part of it, I really do think, and we've argued this since the 80s, about the impact of ovarian suppression with chemotherapy and how it renders that premenopausal woman essentially postmenopausal, and that's why the chemo gives all the benefits. So I'm still not confident that we can say that all premenopausal women with node positive disease have to have chemo. I'm still not sure of that, but I'm very confident not using it. What about you? See, we got that moderator question.
I completely agree. And I think obviously it kind of depends on, the associations of what else is there. But I think in what grade is the tumor and things like that in terms of their absolute risk. But I completely agree with you that, I'm wondering how often we're going to be sending an oncotype or recurrent score, because that's what we would typically do where we are, although certainly I'm comfortable doing the Mamounas. But then when we don't like the score, we're going to now send it for Mamounas in the premenopausal women. Or are we going to assume that for much of the benefit that it is the ovarian suppression effect, the chemoendocrine effect? And, it was striking in the subsequent analyses in Taylor X, where when they looked at the benefits of chemo in the women with scores under 25, the biggest benefit, in contrast to what you would expect, was in the older premenopausal women in that group. And of course, that's probably the chemoendocrine effect, because they're more likely to go into menopause. And only a small proportion of women on Taylor X or on Responder took ovarian suppression, because these studies were all started and mostly completed in terms of accrual, or completely completed in terms of accrual by the time the soft data came out, which was in 2015.
Your 35-year-old woman's not going to become postmenopausal, but your 50-year-old is. Yeah.
But I think the open question is, and we'll have to send them to Dr. Kurra for their treatment of their bones and their menopausal symptoms, and how do we deal without giving them estrogen. But I think the really open question is, is the tumor biology in a person who has ovaries working versus not that different? There are potentially some differences, or is it a host effect of just inadequate endocrine therapy in them, where it makes all the difference below that 25 score on oncotype, or depending on your Mamounas. So I think there's still a lot of work to be done to be teased out. Matt, do you have at the tip of on your slides there what proportion of people actually got ovarian suppression? I think it was only about 60 people, wasn't it? It was a small proportion.
It was 16%.
16%. Yeah, so a real small proportion of those premenopausal women. Thank you, Terry.
It's interesting, if I make a comment, that the results of the Responder on surface look different than Taylor-X, but in reality, they look very similar, right? Because even in Taylor-X, the 11 to 25, most of the benefit from chemotherapy was in the high clinical risk patients, which essentially in responded, all of them were high clinical risk because of their nodes. And of course, that we didn't have in Taylor-X the comparison of 0 to 11. Because those were treated with endocrine therapy, but it's possible they may have gotten some benefit, which I would submit again, my bias seeing the data is probably an endocrine therapy effect, because it doesn't make a lot of sense when you look at the recurrent score and how the increasing recurrent score increases benefit for chemotherapy in postmenopausal, but not under 25. And all of a sudden we see now that 0 to 25 gets benefit from chemotherapy and no difference between 0 to 11 or 11 to 25. And of course, on the other hand, we know that ovarian ablation does improve outcomes from the soft and tech. So I think obviously we need to look at that. That question cannot be answered by these trials, but certainly begs to be answered because that's sort of the last sort of piece of the puzzle in terms of what's going on.
Yeah, no, it's an important question. And there's a question from the audience. Does T size influence your decision on whether or not to recommend chemotherapy in a recurrent score less than 25 patient with 1 to 3 positive nodes? Are you comfortable making the same recommendation for someone with a T3, T4 as in a T1, T2? I could ask our radiation oncologist. Our radiation oncologists often tell us whether they think a person needs chemo or not. You want to start with that one, Christina?
I think that, well, and we're supposed to await the results of Taylor RT as well to see how the recurrent score can also, factor into our potential de-intensification of the radiation fields. But I think it comes down to a lot of like factoring multiple risk factors in as well. The needle has moved so many times in terms of what to do with patients with 1 to 3 nodes positive from a radiation perspective. And depending on how aggressive you interpret, like the MA20 data, for example, or the Oxford overview data, even 1 to 3 nodes did have a benefit. But I think the biology definitely is telling a larger part of the story. And I think for patients where we are favoring more endocrine therapy more so than cytotoxic chemo in terms of giving them a larger benefit, it probably also makes sense to kind of de-intensify the radiation fields as well. But in our large community practice, I've seen kind of the patients where, for example, the medical oncologists feel strongly that they should do chemo. We get something like a recurrent score back and it's somewhat low risk. We kind of convince ourselves, well, if we're believing the recurrent score is low risk and omitting chemo, maybe we should push to do radiation therapy in this person. Even though that is completely not really kosher. And then again, I think when it's factoring in things like the T size as well, we tend to look at multiple risk factors. So not just the 1 to 3 nodes, but rather, the size of the nodal involvement. Is it a micromet? Is there extranodal extension? Obviously the tumor size, but then also things like the grade. Is it grade 3 or is there LVI present? And multiple risk factors, particularly in a younger patient, would make us favor kind of escalating and doing, radiation in those settings for sure.
Yeah, and just to emphasize, the absolute benefits are generally larger when the absolute risk is higher, if there's a benefit to the therapy, right? That's what we see over and over again. And sometimes when absolute benefits or absolute risks are small, there may be benefits, but they may not be worth it to a person because they're so small. And that, Jessica, is how we hope that decisions get made with patients where it's spelled out like that. And as we know, it's quite hard sometimes to even understand all these risks ourselves as medical professionals. So I take my hat off always to the patient who's stressed out, recently diagnosed, and then trying to make these decisions and understand the Greek that we're speaking and deal with the risks. Do you want to comment on your experience with that, Jessica?
Well, again, as I said before, it's really difficult not to retreat into a place of fear. And, I find that the more that our doctors or my doctors empowered me with information and research-based decision-making and trying to simplify it for me just so I could make sense out of things, then, the comfort level increases. Of course, we trust we trust our doctors. You know, you speak a different language and your background knowledge is so far superior to anything we could hope to understand. So, you know, as a patient, we're relying on you really to guide us through. And I think for physicians to, you know, expect a patient to ultimately make the decision on their own and feel confident about that is maybe not that realistic, because we don't have the training and the background knowledge. We really kind of need you to truly help us say, yes, this is the right decision and this is why.
So we're your navigators. You have, but you know, we have to elicit your values. All right, Terry.
My comment for where it's worth in the expander, size did not matter in terms of response to chemotherapy or benefit from chemotherapy. So I think the decision of the question that was asked is for premenopausal patients you give chemotherapy irrespective to tumor size, and for postmenopausal probably you don't, irrespective of tumor size. Obviously the extremes, like in your tumor size was 9 centimeters, obviously you need radiation, but you already had a positive node, so I don't think that matters as much in terms of the decision. You apparently you're premenopausal as well, right?
Yes.
So I think the decision in retrospect, of course, before even the trial was announced, we should do the right treatment, which was chemotherapy.
I would argue, though, that I totally agree for Jessica. Elyse and Matt, just to finish things up here, let's pretend Jessica is 60 now or 55, postmenopausal, not too long ago, coming in with a 9 centimeter tumor, node positive. Are you comfortable giving up the chemotherapy in this setting?
Well, I'll just comment that I think we certainly need to move beyond standard prognostic characteristics and move to biology. We used to make decisions based on stage. We used to give bone marrow transplants based on characteristics, and we know how that ended. So I think here there's really been a push over the last 15 years to make our treatment decisions on biology. And also I think the other thing I'll just mention in that is we routinely make decisions now based on response to our therapies. So in the setting of chemotherapy for triple negative breast cancer, we give additional therapy post-operatively. For HER2 positive, we give therapy post-operatively. And the one thing about endocrine therapy right now is the only situation where we give patients a drug for 5 to 10 years, and we say, we have this static test, but we really don't know how you respond ultimately. We've never actually seen a tumor cell regress or not. We've never really watched looked at a marker of proliferation. And so that's why the ADAPT is such a great idea, because you're going to say, hey, you have to take this drug for 5 years or 10 years, but I don't really know if you're responding or not. I think here's a marker that suggests that is the recurrent score mammoprint that you probably will respond, but I don't really know. If you look at the data from ADAPT, getting back to that, you see marked variation in endocrine response. And ultimately, I think that's where we're going to go. I completely agree with Elyse about the whole issue of Ki-67. We know the issues, we know the problems, and it's going to take some time for us to really bring that out into the community. I think there was a great effort to standardize our tests with ERPR and HER2. Why can't we figure it out with Ki-67? I think it's going to take some time. I don't think we're there yet. I completely agree. And I also think we're at the beginning. Ki-67 is a relatively rudimentary marker. I think there's going to be better ones that will come in the future as well.
Thanks, Matt.
I have when I see a woman who's had a core biopsy and we've sent genomics, be it oncotype or mammoprint or whatever, the most important thing, I think, is to be certain that this is representative of the tumor. So if we really sent the correct specimen and the number is low, I am quite comfortable with giving her only hormone therapy. But what I sometimes see, especially in a 9 centimeter tumor or a 5 centimeter tumor or a 2 centimeter tumor, that it's heterogeneous. And if by chance the core did not send something that's truly representative of the worst part of the tumor, so to speak, the highest grade and so on, then I may be more suspicious. And so, I think you have to be careful. And if you feel it's been representative, I'm quite comfortable with that. I think the science should drive our decisions. So,
Elyse, I think that's a great comment and really important point. And that's why we love to sit with our pathologists as part of our multidisciplinary conferences too. So in our last few minutes, I want to switch gears on a related topic and think about, someone brought up, recurrence, tumor dormancy, and we are obviously doing everything we can to prevent that and learn. And in the metastatic setting, we now have been using the CDK46 inhibitors to help to deal with the resistance that develops to endocrine therapies and to keep them working for longer. And I don't know about you guys, but I tend to have referred to the drugs as kind of Coke and Pepsi for the choices out there, the 3 CDK46 inhibitors that are on the market. And I kind of use the one that I'm most comfortable prescribing and that know the dose and manage the side effects unless a person has some toxicity. But in the last 6 months, that's kind of been blown out of the water a little bit, at least with the early stage. So I'm wondering how you guys are reconciling the Palace trial that was presented and updated in some ways at San Antonio, which looked at the use of adjuvant palbociclib with the Monarchy data that we saw also updated from ESMO to San Antonio with a couple more months of follow-up. First, I'm going to ask the question of, is it changing your approach in the metastatic setting? Is anybody doing anything differently in the metastatic setting, or the data are what they are and we're comfortable, they all show a survival advantage, and you pick the one that you're comfortable with or that's right for that patient? Elyse, do you want to start?
And I agree with your comment of it's Coke and Pepsi or whatever, but I do think that they're not the same. And I think as we've had more experience, these are different drugs. And I am not surprised that we're seeing better responses in some of these studies. So I've not changed any of my metastatic prescribing right now. Do you think that I view in the early stage that these are probably different drugs and we got different endpoints, and I'm going to go with the drug that shows the best response. And so in this case, abemaciclib was totally a winner. And I think that that's important. Will there be more study? Absolutely. And I'm sure that there'll be more data, longer follow-up, I'm sure there'll be much more data down the road that may change, but based upon what we know now, I don't think they're interchangeable. And they're not interchangeable in the metastatic setting either. I think we just don't fully understand it. And I think as we go forward, I remember when the aromatase inhibitors came out, there was the FACE study that compared anastrozole with letrozole, and it was a draw. I mean, there was really no difference. I'm not so sure that that is the case with the CDK inhibitors, because when you deep dive, they're not the same drugs.
Yeah, all 3 show benefit, but I think you're right. So metastatic setting, we've got good data to support them all. I think in the adjuvant setting, Matt, do you want to comment on Penelope B or Monarchy, or Terry?
So I think when it comes to the CDK46 inhibitors, I would agree with Elyse, they're not the same. Certainly in the metastatic setting, when we start these drugs, when we look at the hazard ratios, at least for PFS, they look very similar. Not all of the drugs have shown a survival advantage in the metastatic setting. And so some people would argue, well, we just need longer follow-up. I think if you just look at the first line therapy, let's say a woman who has lower risk features, let's say ER positive bone only, I think a major question that remains right now is, do we start with the CDK46 inhibitor up front, or can you actually delay it? And that, of course, we don't know the answer for. And there's a trial that's actually trying to answer that question in Europe, the Sonia trial, and I think that's going to be a very important study. But getting back to the metastatic setting, we treat until they progress. In the adjuvant setting, we're treating using the drugs, and we're stopping. And interestingly, with the Penelope, it looked like there was an initial benefit, and as they stopped the drug, the curves came back together. And that might suggest something about what these drugs are doing. We've gotten hints from that from some of the preoperative studies. When you stop the drug, the Ki-67 goes up. And so how is abemaciclib different? I think that's still an open-ended question. I think that's still really early. We need to see what happens to the curves when all the patients stop the drugs and we get 2 to 3 to 4 years out. But clearly at the early time points, they look different. And I completely agree. And I suspect it's because the drugs are also different. And there's a couple hypotheses about that. Those have been discussed previously, but the early data suggests they are different.
Yeah, I mean, and you know, obviously, you know, we have two negative trials with Palbo now, one with 1 year, one with 2 years. The other thing is maybe the continuous versus interrupted dosing, which we don't know, and of course, whether 3 years is better, we may find out from the Natalie trial. So I think there may be differences, though. I mean, I say that having lived through the AIs back in the day, where we, as Elise mentioned, we were debating how much you can lower the ER levels and so on and so forth. And at the end of the day, there's absolutely no difference. But I think these drugs may be a little different, at least in the early stage setting.
Thank you. There's a question from the audience that asks, currently, if you have 4 or more positive nodes with low recurrent score, e.g. a 60-year-old, then adjuvant chemotherapy is recommended. Do you expect that to change in the future? That's a very good question. You know, they were all excluded from our responder, and we normally wouldn't necessarily send a recurrence score on someone with 4 or more positive nodes because the absolute risk would be higher than we'd like unless someone was very chemo averse to make ourselves feel better. Elyse, you're shaking your head.
Yeah, I in general would not send it on 4 or more positive nodes. We just don't have any data, and so I don't know what to do with that. So, and I don't think we'll get any in the near term. So it will be quite a while before we know that. That's where I think you have to make the decisions based upon other features, other biologic indicators like grade, and back to the famous Ki-67 and others that may help us a little bit to determine that.
Yeah.
But I do think that there's going to be some bleeding. I think there's nothing magic about 3 nodes versus 4 nodes. I like to think of it this way. If you had a patient who was 62 years old and she had widely metastatic disease that was ERPR positive, HER2 negative, would you give her a chemotherapy versus endocrine therapy? You would. You'd say, well, the correct treatment here is an endocrine therapy approach. So I think we don't have data. Completely agree. But I have to wonder whether adding that one lymph node is really different. And I think for those patients where they're looking me in the eye and saying, do I really need chemotherapy, Dr. Goetz? And why should it be different since I have 4 versus 3? I have to be honest and say, I don't think it probably is much different. Now, I also know that the more disease you have, the more greater heterogeneity, chance for heterogeneity. You made that point. It's an excellent point. But I think we're going to face that question on Monday morning.
Yeah.
Well, it's already Monday, right? Oh, Terry, go ahead.
No, I agree we don't have any data on prediction, although I agree with the comments of like 4 versus 3. I don't think it was going to make much difference. But I was going to mention that we do have some data from one of the old NSEVP trials that we did, the recurrent score B28. And in B28, everybody get chemotherapy. So there was no endocrine alone. But we looked at the recurrent score for local regional recurrence, but also we assessed it for distant recurrence. And prognostically, at least, patients with even 4 or more positive nodes, but a low recurrent score actually did better than those that had 1 to 3 positive nodes with a high recurrent score. So prognostically, the recurrent score was more prognostical actually than the number of nodes. So, and that was true for local regional as well as distant recurrence. But you can't tell anything about treatment because everybody gets chemo in that study. But there's something there.
Thank you.
And do we have time if I could raise a question for the panel? Are we?
Sure.
So I want to ask a question, and Terry and I have been thinking a little bit about this recently. So for a premenopausal patient who comes in, undergoes surgery, and you run, let's say now you order a recurrence score, let's say she's node negative. Does the timing of the menstrual cycle impact the recurrence score?
I don't think we know. Do we have any data on that?
I don't think we have any data, but this is beginning to come up a little bit. And, certainly if people are beginning to make decisions about use of chemo versus not, simply based on a number that could change, variability from one part of the cycle, follicular phase versus luteal phase, I think it certainly is of interest. Certainly there was a large clinical trial that addressed the timing as it relates to surgery, showed no difference with surgery. But it is something that Terry and I have been thinking a little bit about as well, and wondering if anybody else had thought about that.
No, and I think it would be a really hard thing to study well. But we could ask the companies if they have any data on that, right? That make these genomic expression.
I don't even know what we collect. Dr. Kurra, what would we collect to try to, it'd be difficult.
Yeah. You can collect the core biopsy,
Yeah.
and you collect the surgical specimen, and those will be in different parts of the cycle potentially, or you look at if there are any differences, if in different part of the cycle versus
Yeah.
the no differences in the same part of the cycle.
Do a recurrent score in both.
Yeah, I mean, it's a very provocative question I think Matt raised, and I don't think we can answer it right now, but.
So we only have a minute or so left. So I'd really like to thank this illustrious panel. It's been terrific to converse with you for the last hour. Jessica, do you have any final comments you'd like to make? Because you've got a captive audience of providers listening to you and helping us to take better care of people who've been diagnosed with breast cancer. Do you want to have one of the last word?
Well, thank you. You know, I will say that I think overall, it sounds like obviously we need more data. I appreciate the work that you do, but as a general rule, as doctors in the field, don't underestimate the power of the multidisciplinary approach and the power that it has to involve all of your extra medical professionals that are able to work with your patients and help supplement the support and information to help guide patients through this intensive cancer treatment regimen. Because, you know, you have a certain role, and to ask you to do more than that, I think is a huge ask. So using, you know, that multiple disciplinary approach, I think is beneficial to all patients.
Well, that's good to hear. And it's great to hear that you appreciate it, because we agree with that. And it makes it much, you know, we support each other and try and learn from each other, as you can hear, and we come up with studies and other things to think about also to move the field forward. So thank you. And thanks to all of you for your participation in this panel. It's been a delight. And thanks to our sponsors for making it all possible. And to those of you listening out there, thank you for your attention.